Parul thought of having a case which I always remember or never forget. And we are eager to listen to you because you are a legend, and the experience which you have, I know, and the teacher of teachers now. Once again, I welcome everybody. I welcome Dr. Madhuri as Honorary Secretary, General Secretary of FOXY. And on behalf of everybody, very good luck for this today's program. And sir, uh, we are really eager to listen to you, the case I will never forget. Yeah, thank you.
So thank you, Sheila Mane madam, and really very good evening. And I'm really feeling proud and privileged to welcome all respected, especially Dr. CN sir as guest speaker, and Madam you, Dr. Sheila Mane as Vice Chair. Madhuri Patel, Madam, I'm really feeling so happy to see you, our Secretary General, who is so dynamic and always, try to join our programs. And as Parul Kotawala sir, he is busy with some emergency conditions, so he will be joining a bit late. And also I welcome my dear friend Kiran Pandey, who is a co-convener of this program. I will never forget. And this program is really doing very well. This is the third episode we are having. And last two episode was really very, lots of people, they were listening. So today we are here to listen our respected CN sir, who is going to talk about the case I will never forget. So over to you, Dr. As Sheila Mane madam, we have already welcomed everyone. If you want to say something more, you can say. Dr. Sheila
Dr. Vinit.
Yeah.
Patel is there. Dr. Madhuri Patel madam is there now. So she can give
so madam,
welcome from address by deputy.
So okay.
So
I would like to call, yes.
Respected Dr. Jaideep, our President FOXY, my mentor, Professor C.N. Purandare, Dr. Parul Kotrawala, Chairperson of the ICOG, Dr. Sheila Mane, we just heard, the Vice Chair of the ICOG, Dr. Sarita Bhalerao, she just came from the Caesar and we are in time, Sarita. And of course, our today's expert, Dr. Atul Munshi sir, Madam Shanti Roy, Convener Dr. Vinita, Dr. Kiran Pandey, and all my dear friends. Very good evening to all of you. At the outset, I would like to thank entire ICG team for giving me this opportunity. I have so many things to tell about sir that I cannot finish in 5 minutes, but I will try to finish in 5 minutes. That sir is a great mentor, orator, great surgeon, great clinician, and he's always great, excellent, student-friendly mentor. You call sir anytime. At any hours of the day and night, he's always there to guide you. I remember sir has guided one of our student had, PPH. So sir has guided on the video call how to do internal iliac ligation because he was far away from Mumbai. And so many times sir has helped all his students, and he was there as an honorary over Grand Medical College for more than 20 years. And I remember, sir, that he used to take every Wednesday from 7 to 10 p.m. PG classes for all the students from Mumbai and others who were there in his clinic, every for 20 years. And he has been admired by all the students. And sir, as far as myself is concerned, whatever today I am as a Secretary General of FOXY as well as Editor-in-Chief, I owe to sir everything. Secondly, he has not only taught me clinically, but also taught me nitty-gritty of the FOXY administration, as well as he has taught me the difficult surgery. And he catches all his students and teach them how to operate. So with this, I would like to say we all are eager to hear sir his unique cases, and I'm many times a part of his cases, so I would like to hear from sir and our expert Dr. Atul Munshi and Dr. Shanti Roy, their experience, who are also again excellent teachers, mentors, and experienced people who will give us inputs which will help us in day-to-day practice in such cases when they come. So I congratulate the ICOG team for the most apt web series, The Case I Can Never Forget, of third series. And I congratulate and I wish them best luck. Thank you once again.
Thank you, madam. So everyone is eager to hear CN sir, but before I would like to introduce our experts, Dr. Atul Munshi sir. I'm really very thankful to you, sir. You accepted our invitation. And everyone knows you, sir, as you are about you, sir. You are ex-professor GCS and NHL Medical College, Ahmedabad, and he was president of IMS 2010, chairperson ICOG 2014, senior vice president FOXI in 2007, chairperson AIDS committee FOXI in 2002 to 2007, president Ahmedabad OBGYN Society 1995 to 1996, IMS representative to International Menopause Society, convener of Academic Council ICOG 2015 to 17, FOXI representative to CEPHOG in 2016 to 17, and on editorial board, it was Pediatric On-Call Journal and Journal of Midlife Health. So as expert, you are here, sir. And our next expert is none other but Padma Shri Dr. Shanti Roy, madam. I don't know whether she has joined. She is trying to join. And she is a well-known personality of our, of India. And we all know she is teacher of teacher, and she was president of POGS, and she was professor of and HOD of Patna Medical College and Hospital. And her area of interest is autism, high-risk pregnancy, and prevention of cancer. So over to you both, madam and sir, to introduce CN sir and start the scientific program.
Thank you, Vinita. Thank you for inviting me for this particular thing. Dr. C.N. Purandare did not require any formal introduction. Everybody knows that he was president for FIGO. Very few people have come FIGO president. He is one of them. He was Dean College of this obstetric and gynecology. It was his brainchild. It has been started before, but he became Dean for a very long time, and he has brought the thing to present circumstances. He was president of FOXI also, and there are a lot many things which has been there. But most important thing, we are sharing the same birth date, 1812. So that is my privilege that I am born on the same day. He is a man with mission, and many more things which are going to come. When people are after CS, he is trying to bring down the vaginal delivery and what are the methods by which it can be done. He was respected everywhere. Beyond that, I know that he's involved in academics. He was involved in other things. Apart from clinical work, he's a very good family man. He is all half the time he's here, half the time he's at UK, and he's looking after his kids and the grandkids also. So welcome. I'm rather wasting time in between. I request Dr. Purandare to start his thing. He is going to, as in usual style, he's not going to say the same thing in a usual fashion, case discussion. He is going to do it in his own way. Let's hear what he has to say.
Good afternoon, everyone. And at the outset, I just want to mention some of the things. It was in January that Parul Kotadawala asked me whether I would be able to join in one of the programs during his year. And I promised, and I said yes. And it has been 9 months now that I have been able to find time to give him and Sarita to speak on this program. And luckily, today is one of the most auspicious days. We have Anant Chaturdashi. And in front of my house at Chopati, we have maybe 1 million people thronged on the Chopati sands, immersing the Ganpatis. And I, at this point of time, when we are talking about Visarjan, the act of Visarjan teaches us to let go of something we love so deeply. It teaches us to surrender to faith over intellect. And it also teaches that what we love, we may have to leave so long, love unconditionally, whatever that you are enjoying about. And the Lord really neither arrives or leaves. He has existed before time and will exist beyond. Ganeshotsav is a symbolic of our life. We arrived, we celebrate, we merge into the elements. So we have to, when you reach the fag end of your life, you realize how important it is to enjoy life, whatever that you face and you come across. So today, when I'm talking about, I'm not going to talk about, I'm going to deviate from the normal procedure of just giving one case and then talking about it. But I'm going to give you some interesting insights of the residency terms, the teaching from your teachers, and then go on to 4 or 5 very interesting cases which we learned. I learned a lot, and I am sure students here will learn from what I have to say today. It's not a question of discussions on, we are talking about a topic and we are not going to discuss any subject as such, but what do you learn from some of the cases that we face? And I remember the residency days in way back in 1975, when the family planning was absolutely in full swing, and every termination that one did, we had to make sure that IUCD was introduced. And we had to report to the head of the unit if the IUCD was not done, why it was not done, anything, any specific reason that you only did MPT and let the patient go. So I remember one patient whom we were trying to convince in the OPD for a long time. And she kept on saying, no, I don't want any IUCD. I just want a termination. So finally, when she was on the operation table, I said to her that, why don't you take this IUCD? It will relieve you of all the problems. So she said, no, I'll be careful. She said, if you were careful, this would not have happened in the first place. So after a lot of persuasion, I was trying to say it, and she said, it will not happen. This was a mistake. It was my husband's birthday. So there's some funny incidences that happened. Then we are really, the entire OP was in splits when she said that it was my husband's birthday when the mistake happened. And the another case that I remember in the one of the OPDs when we were there in the morning, and there was terrible stink in the OP. We were all wondering where the stink was coming from, and finally everybody gravitated to the medical OPD where the stink was coming from. And that time, I'm sure some of you know the registrar was Dr. Altaf Patel, who eventually became a professor in Grant Medical College and retired. Professor Latif Patel's son, who was the registrar at that time. And he walked in and I said, what is happening? And I mean, it's so much stink all over the place. So we were looking and there was a couple sitting there with a couple of tins around them. So we asked the ward boy to find out what was happening. And the husband said that ये container लाया है, इसका वास आ रहा है. So I said, what is all this? He said, last week when we were here, डॉक्टर साहब ने बोला कि संडास का तपास करना है. So 8 days wives stool he collected in the containers and brought 4 or 5 tins of the dalda containers in which stool was collected. So this is how patients respond. They don't understand what it is if we don't explain to them properly. This is what you see happening. So these are some of the interesting situations that as the residents, I'm sure all of you have gone through many other very interesting and funny stories which one faces. But as far as the teaching from seniors is concerned, I remember 2 incidences, which one is when I was a registrar in Bhagwati Hospital under Dr. G.B. Bailey. And one day we had a PA service case, and we did a radical Verdun hysterectomy. And a week later, there was another case of radical Verdun hysterectomy. She was on the operation list. And we were waiting for the boss to come, and he walked in and he said, "What are you all waiting for?" So I said, "Sir, the radical Verdun has to be done, and we are waiting for you." They said, "What is there to wait for me?" I said, "Are you doing the case?" So he said, "I showed you last time. You know how to do a radical hysterectomy. You have seen it. You have to do it. I'm here around to see if there is anything going wrong. Go ahead and do it." And look at the confidence that the bosses used to give to their registrar those days, where you could second surgery, first watching it, and the second surgery, he asked me to do it. He was there standing behind me, and I did a complete radical Verdun hysterectomy. And when I went to Ireland after finishing my MD, and I had the resume submitted, my boss there said, "You have done radical Verdun hysterectomy?" I said, "4 of them in my residency as a registrar." They said, "You don't tell anybody, because people will think in India anybody does anything." But the very fact that that kind of training was done is something phenomenal. And the same boss in Ireland, after asking me to do vaginal hysterectomy, the same first operation day, said to me, "Well, you know your job. Henceforth, if there is any emergency, anything, just go ahead. You don't have to inform me." And that is the kind of confidence one gets when you work under people who have given you that. And I remember Dr. Meehan, one of the cases where I was doing abdominal hysterectomy, and I opened the abdomen, and besides round ligament, I couldn't do anything. The entire pelvis is fixed with the tumor, and it was like a frozen pelvis. And I couldn't move any further. So I called him, and he came and had a look at it, and he said, "Young man, do you want to do this hysterectomy, remove the uterus, or you don't?" So I said, "Obviously, we opened it with the intention of removing the uterus." So he said, "Move aside." He put his hand in. He was with his fingers going deep down in the posterior pouch, bent inside, and then he said, "Jesus Christ," and he pulled the whole uterus out in his hand. I couldn't believe it. And I mean, today's day and age with medical legal, there's no way one can do that. But he took the uterus out in his hand and took it out, and he said, "Now you ligate the vessels and look at the ureters if they are not." So this is the kind of confidence that one gets when you work with people who are themselves there with utmost confidence that they know whatever the problem, they will be able to sort it out in case the situation arrives. So these are some of the interesting things I thought that I will mention, because a lot of juniors will be here, and training people as a teacher, how it needs to be done. Now I'm going to go on to the various cases. And the first one is a very interesting case. I saw a lady in 2013, and she was married in 2010, primary infertility. And she came to me and she said, they have problem having intercourse. So I presume that maybe vaginismus or something or the other may be there, and the husband may be having some problem. And when I tried to examine, I couldn't even put my finger in. There was a lump inside the vagina, big lump. So I put a speculum from the side very slowly, and I saw that on the right side, more than the size of a cricket ball, there was a lump which was encroaching onto the vagina. And it was literally obliterating the area, and obviously they couldn't have any intercourse at that time. And I got a UHG done, and it showed a mass between the vagina and the rectum, and the side of the vagina on the lateral wall. And the MRI findings suggested that the possibility of vaginal leiomyoma. But this was something which I had never heard and seen in my life, to see a vaginal leiomyoma happening. With the uterus was completely normally sized. adnexa were normal. Nothing was there except that this lump which was there in the vagina. So I decided that that lump had to come out, but we decided to take it out vaginally because if infertility patients going up from above, deep down into the pelvis, trying to get the tumor out from there, which was near the vagina, it would cause a lot of damage. So we decided to do it through the vagina. And I took a vertical incision on the lateral pelvic wall. And just as you would do a P repair and you dissect the rectum out from the vagina, I dissected slowly the entire tumor out from the vaginal border. And there was little vascularity which was connecting to the tumor from the lateral wall to coagulate those vessels, and eventually took the tumor out. And the histopathology report came as leiomyoma of vagina and query from cervix, query from cervix. So maybe it started off with cervix and went down into the lateral part, lower down, and probably got detached also. God knows how it landed up there as in the vaginal wall. So the operation, even though was not very complicated, took me a long time to take it out because I was a bit worried that the structures around me get damaged and so on. Having done that, she subsequently conceived after 2 years, had a cesarean section with twins, and came back to me in 2022 saying that she's getting severe pain on the right side, lower abdomen. I examined her, and again there was a lump which was felt in the right adnexa. Got an MRI done, and it showed that there was probably deep endometriosis. The lump which was there, which was in the posterior fornix, extending there and very close to the rectum. And PR examination had shown that the lump was very close there, it was fixed. Unfortunately, I have not been able to operate on her now because she had to delay the surgery because of her twins, and she said that when the vacation is there and husband is able to look after the children, she will have the surgery done. But these are different technologies, and when you're talking about endometriosis, deep pelvic endometriosis arising there, and you had a lump on the same side which was histopathologically a leiomyoma of vagina and probably arising from the cervix. So a very unique case. I've never ever seen a situation where there was a lump arising from the in the vagina. So this was one very interesting case, and I hope I'm able to operate sometime during the vacation now to find out what it would be. And I gave her the option of deep endometriosis to do by laparoscopy or open or whatever that. She said, I do anything now. Now I don't mind what it is. I have 2 children. And even if you remove the uterus, whatever the lump is, I'm fine with it. There is no problem if you're doing it from above and taking it out. So the option and permission to hysterectomy is there when we go down. And I don't know how badly it would be adherent to the rectum, whether we need to do anything, particularly with the rectum, and so on. So this is one very interesting case that I encountered. The other one is when I came back from Ireland in 1983, 1984, one of our close friends, she'd had 2 cesarean sections in the past and 1 ectopic pregnancy. And she walked into my clinic and she said that you look after me, I'm 6 weeks pregnant now. So I examined her, and there was a lump on the side. The ectopic was done on the left side where salpingectomy was done. The right side an ectopic as well. So I explained to her what the situation was. She said, you save my tube. Because those days in 84, it wasn't the IVF era where anybody could do IVF subsequently. And that going, if salpingectomy was done on the right side, it would have been the end of her obstetric career. So she insisted that somehow you must make sure that my tube is retained. And I said, okay, we'll try. And the ultrasound confirmed that it was ectopic, it was ruptured, and it was leaking also there. And she walked out of my consulting room, and the next thing my secretary said is that the woman has collapsed. She was down on the floor, and we picked her up, took her straight to the theater. I opened her up, and the right side tube had ruptured. There was ectopic which had ruptured. Now, the big decision was to save the tube. A big lump, 6-week size pregnancy, ruptured, bleeding, abdominal. So I said, okay, let me try. And we did a wedge of that fallopian tube, which had ectopic in it. And with 6-0 suture, joined the two ends together and leaving epidural catheter in the cavity while suturing, so that the suturing was, it was mess, blood, and it's not easy to do microsurgery in those situations. And in those days, we didn't have routine microscopes which were used. But Atul will remember, we used to have those specs which would give magnificence to about 6 or 7 times, and you wear those specs and see the fallopian tube and do the anastomosis there. So I finished the anastomosis, I did that, and she recovered well, fortunately. And imagine 2 years later, she conceived again. She had a boy, and she was delighted because actually she wanted to continue the obstetric because she had 2 girls, and there was family pressure that you must try for another one and so on. So she had a boy, and I delivered that boy when I did a section again for her. And unfortunately, for next 25 years, maybe, from 84 to maybe 2020, but more than that, about 2 years ago, for every little thing she would call me. Even if she had diarrhea, to whatever, she would ask me and take medication. And she never went to anybody. And in 2022, when she had abdominal pain, GI upset, so she went to somebody else, a GI specialist. The GI specialist looked at it, and whatever treatment that had to be done, did that. And still the problem continued. And then they did a CT MRI. It turned out to be a pancreatic cancer, stage 4. And the woman died within a year. So how destiny takes from one end to the other. And I said to her when she had pancreas, I said, you call me for every small little thing. Why didn't you call me when you had pain right in the beginning? She said, I thought that it was stomach pain. Why bother you? So this is the situation that you face. And the most important thing is, do not disrespect the patient's decision, and you try and accommodate as much as possible. If the situation was bad and we had to do something different, but don't try to thrust your opinions on patient. Give chance to the patient to do exactly what they desire and they want. And ultimately, the happiness of the patient is going to be beneficial to you in the end when you're talking about happiness as is. I'm going to talk about another case, which is in 1975. When I was a house officer, I had 2 bosses. One, Rohini Merchant, who was the head of the unit. Dr. Nanavati had retired that time, and Rohini Merchant had taken over. And the lecturer was Champa Naryani. Both of them are no more. But I was asked to see a patient by my brother-in-law who there was a guy whose wife was complaining of severe pain in abdomen. So she came and we examined her, and there was actually from the cervix phosphoring. Those days, the ultrasound was not so efficient, or there was no CT MRI to check out things. And in a general hospital, one couldn't do all these things. So anyway, with this severe PID which was there, the boss said, we'll open her up and we'll see what to do. So when we opened her up, there was bilateral tumor masses with pus. The cervix, anyway, pus was flowing out from the uterus. And she said, oh, this is mess. We have to do a hysterectomy. Now, this girl was only 22-year-old, 2 years married, no children. And the boss said, no, let's take this out. This will kill her. So I was kind of kicking the lecturer, Champa, who was standing next to me. I said, please tell her, don't, because I have not even taken consent for a hysterectomy. She will be thrown out of the house in the village. So finally, Champa convinced Dr. Merchant that, no, don't do hysterectomy. We'll put drains, we'll give her higher antibiotic, whatever. So we finished with that. She recovered. She went home. About 8-9 years later, I saw her, 3 children. So obstetrics and gynecology with us, there is never a dull moment. You see things happening which you yourself may feel that, well, this can never happen, and it happens. So it's the same situation where you're trying to do a hysterectomy for pyometra and so on, and she recovered completely to deliver 3 children. Just imagine. And I really felt that I was thankful to that decision that we took, that we didn't do a hysterectomy at that point of time. And the patient subsequently conceived, and it's really something. That's why I remember giving a talk at one of the FOGSI conferences. Obstetrics and gynecology, especially obstetrics, never a dull moment. You can never know what will happen, when, and at what time. And that's something which is very important to learn, that there is never to any situation as far as our subject is concerned. And I remember once my registrar, I don't know, any of them may be listening to me here at this point of time, called me up in the evening around 6 o'clock that there is a very senior obstetrician gynecologist in Mumbai, and his wife is also a gynac. They are running a hospital. They are just called to say that they're transferring a patient who has been given 6 units of blood in the last 8 hours post-delivery. And they gave 2 bottles of blood. She recovered. Then again, she started bleeding. They gave another 2 bottles of blood. She recovered. And then 2 hours later, another 2 bottles again went into shock. So I heard all this on phone, and I said to my registrar, I said, prepare theater. She has inversion of uterus. So my registrar said, you haven't even examined the patient. I said, my hair haven't gone gray this night. If a patient recovers after 2 hours completely and then collapses again, there has to be some reason. It's not, if the uterus is contracted, why should she bleed and why should she collapse? And there is a reason. So we took her to theater, and the Grant Medical College is renowned for a Shivkar pack, which is the balloon pack, which condom pack, which was the first condom, the balloon. After that, the Bakri balloon and ivory, all sorts of things came up. But it was Shukar who designed that balloon pack, and we put that balloon in, gave her medication, and slowly they deposited it, gave her medication, and she survived. And that's importance is the diagnosis, because when the registrar went into it, he said that there is a fibroid which is prolapse from the fundus, and that is causing pain. So this is something which is important. And the last interesting case that I'm going to mention is what Madhuri mentioned just now when she was talking about my student. And in way back in 1998 must be where when the mobiles had just started, and we all had mobiles. I think mobile started in, if I'm not mistaken, around 1995. And this was around 1999. Previously, we used to have those bleepers, which could bleep to tell you to call back, you know. But the mobile started in 1998. And one day in the night around 12:30, this boy who was my house officer and finished his DGO, and he was from the government service, and he went back into interior of Maharashtra and as a medical officer, and simultaneously had a maternity mode and so on. And he called me up to say that he's the patient who's opened up, severe PPH. All the tricks have been tried and she's still bleeding. So I remember you doing internal ILAC ligation in JJ when I was a PhD student. I don't know how to do it. I don't have the confidence to do it. What do I do now if I don't have expertise to get an internal ILAC ligation done? I said, if you have seen me do it, there's no reason why you can't do it. It means I will explain to you how to do it. And on the phone, he was listening to me and I was dictating to him. I said, you go identify the common iliac artery, internal iliac, external iliac, take an incision there, open the peritoneum. You will see the artery there, you will see the vessel. If you can't figure out internal iliac artery, it's still very simple. Go to the common iliac artery, go under the common iliac artery. So he went under the common iliac artery. I said, you can see now the external iliac artery? He said, yes, I can see the external iliac artery. Then I said, you go from lateral to medial side under the external iliac artery. So he took that and I said, now you pull the stitch and it has to go on the internal iliac artery. It will not go anywhere else. And he tied it, both the sides, internal iliac artery. Patient survived. So we are talking about AI today, artificial intelligence, where you are going to transfer things, technology, online, offline, and so on and so forth. This is something which has happened in 1998. So if there is a will, there is a way. And I mean, you can do these things whichever are appropriate to do it. And at the end of it, the patient survived. So this is something which is we must learn from all these things that are happening. And I mention all these things purely for the residents and purely for the junior colleagues that innovation is important. You must learn to do things. You must try to get your, when you are treating patients, don't try to be dogmatic. Don't try to push your ideas through. And most important, because you get referrals from so many patients, consultants, which patients come from different consultants. First and foremost, golden rule, do not undermine or put down your colleague by saying that, well, that person has done rubbish. I am going to do something better. No. Situations happen, difficulties also happen, complications also happen. That doesn't mean that the same complication can happen from you for some stage or the other. And you must learn that being civil, being good to your colleagues, to your residents, your students, make a lot of difference. And when Madhuri said that recently in Mumbai Society, they gave me a Dronacharya Award for my contribution to teaching. The most important thing is that as a teacher, as when you are giving all these incidences, and as a teacher, you must realize one important thing, that is that the students whom you are teaching are like your children. If you don't nurture them, you don't bring them up in life, you have failed as a. So this is something which I thought, and I think Atul, you took my punchline out of the thing when I was going to say that Atul and I same the same birth date, and we have always wished each other all these years on 18th of December. Thank you very much.
Thank you, Dr. Purandare, for pearls of wisdom. I still remember before 40 years, 50 years, when we started practice, there was no telephones, only landlines were there. When we go out for picture or something, they used to put on a board that such and such person is required for an emergency. So things have completely changed. If we talk this to our children or even to our patients or even to others, they will not appreciate it. But we know that what things we have gone through. We were not having ultrasound. An MRI was out of question. X-ray was there to find out whatever is there now. In those days, God was always great. And as he has mentioned, yes, so many cases. We also had so many cases. Small uterus, very poor count, and they used to conceive. So it's all difficult things. God is always there. You mentioned about various cases. Let's have a discussion if you want. Then I'll go back for my comment. Anybody is having questions about it? Madhuri? Anybody from the audience? About his first,
I can't hear.
about his first case, about Vardheim, we used to say that see one, assist one, and do one. But it's not that easy, especially when it's a question of Vardheim. It's only people like Dr. Purandare can do it, not other people. They used to see so many cases and then you can do it. But that is one important thing. Our places also, people used to teach us. They used to see that you see this patient, then they will ask them to assist, and then we used to do it. But people was always there behind us. Dr. Shantiji has already come. Dr. Shantiji has already come.
Atul, talking about radical Vardhams, I must give a very interesting thing. When I submitted my paper in 1994 at FIGO on modified radical hysterectomy with the vaginal and abdominal route combined. And that's known today all over the world as Purandare's modification of radical Vardhan hysterectomy. And in the Paris Congress, they asked me to speak on CA cervix. 90, 70, 90, together we can succeed in reducing cervical cancer. But this modified cervical cancer came up very interestingly, that I was doing radical Vardhan hysterectomies, and I realized when I was in Ireland that in spite of the reports which came back as vaginal vault clear and so on, patients landed up with vaginal mets after maybe 4 years, 5 years, and we couldn't fathom why it had happened and why it was happening. And I had a very close pathology friend. He was a consultant that time, but he was a very close friend. And he said to me that, give me a strip and let me see what it is before and after. So while doing a radical hysterectomy, what we did was we took a circular strip of vagina from below and send it for examination to see whether there was any. And he said, I have a dye which I can inject from top to see if there are embolization in the vagina. And he checked it and he said, there is no, and what we had done was, we had only resected the anterior portion, posterior portion I had left it as is, and did the radical hysterectomy, upper 1/3 was removed from above and so on. And he said that while the manipulation is happening, while you're holding the uterus, fallopian tube, this, that, pulling the uterus out, embolization occurs. And he saw that in the posterior vaginal wall, there was embolization, where the anterior wall, it stopped, where I had already taken an incision. So we decided that next couple of cases, I will remove the from below, a circular incision, dissect the vagina out, which will be going out from above, while below you suture it and close it. And we did that, and the meds completely disappeared. And I mean, we never saw any vaginal meds happening. And after that, I must have done over 250 or maybe more, 300 radical vaginal hysterectomy with vagino-abdominal approach. And I remember sometime in maybe 2012, when Tata Cancer had an oncology conference, and the radical VADAMS was being done by Hexter Neck from Hong Kong, who's supposed to be one of the top cancer surgeons, and Leblanc from France, who had come, who was doing the laparoscopic resection of lymph nodes and everything. And I was chairing that session that time. And Leblanc started doing the laparoscopic work, and he, after getting the lymph nodes out and the coronal structures, before going down, he said, now I'm going down to the vagina to remove the vagina from below, the upper 1/3. So I said to him that I have been doing this for the last 15, 20 years, and none of these oncologists feel that they think that because I am a vaginal surgeon, I want to do it from below, and they can very well manage it from above to take the upper 1/3 of the vagina. So he said, what he said was so pertinent. And I realized that when I was the FIGO president. He said that now that I have done this from below, and I have removed the vaginal area and removed it from all these people who are sitting in front of me and saying, wow, that's great. And when you were saying, they were not listening to you. And that's the problem with our people and abroad as well. Because as a FIGO president, I realized that how much is the overall impression that I shouldn't be using it, but I am using the word Goras. They feel that anybody who's colored doesn't know what to do and how to do it. But believe me, I have been to 70 countries all over the world, and I've been to various theaters and seen in operating. The Indian surgeon, gynecologist, obstetrician, whatever it may be, is the best in the world. There is no two ways about it.
Today also a lot of laparoscopic surgeons are there, and as you said, secondaries and other thing development is quite because people don't remove it from vagina. That's a fact.
No, the trouble is that you can't go overboard about anything and everything.
Right.
Just because you have a gun means you shoot on everybody is not the solution to the problem. There are various different, I'm not suggesting that laparoscopy should not be done for
No, that's right. It has its own place.
Yeah, even now, today,
Yes,
for a normal size uterus, you see people doing laparoscopic hysterectomy saying that the minimal invasive, they made 3 holes from above,
Yes.
when no hole from below, and I am able to do it, take it out the uterus from below, where the
Natural opening.
existing port is there. So
Yes.
this is what the situation is. So every instrument, every technique has its own place, and it doesn't mean that that technique is the best technique and nothing else should work.
About the second case, a vaginal tumor, you always say abdomen is a pendular box. You can find out anything. Similarly, in vagina also, we come across so many things. Prolapse is the commonest thing. Big cystocele, inversion, as you rightly mentioned about it, polyp, various types of cysts, and even endometriosis has also been found in vagina. So we have to be careful before diagnosis. So people nowadays, they don't even put speculum or other things. They just put on the probe and they try to find out all the things. And that's the reason they are missing lot many things. So that is also very interesting case. And you rightly mentioned about the cyst, when the whole story also. So that is also very nicely mentioned about it. So people should know about it, that vagina is also there. You have to be very carefully see and diagnose it properly.
Yeah, it's important because when as examiners we always ask, what are the tumors that you see, retroperitoneal tumors in if there is a mass in the lower
Yes.
pelvis. These are the standard questions which are asked in MD examination. So there are different things. And what as a gynecologist we are looking at is that the student would know that there is something like a rhabdomyosarcoma, which can arise from the hollow of the pelvis, which will look like all you to those days. Of course, there was no MRIs and so on to identify those. So these are the various different areas, different tumors can come up, and you must keep in mind that there are so many other possibilities and not only one.
Yes, so Shanti Roy, madam, as expert, she is also here. So, madam, can you share your experience regarding, madam?
She's muted. She's muted.
She's muted. She needs.
I think madam is there, but she's muted.
Yeah, she
Gauri,
need
Gauri,
to
can
call
you
her
unmute?
and tell her to unmute.
No, Gauri has to unmute.
Yes, ma'am. Yes.
ICOG team, please unmute Shanti Roy.
Whole team has to go.
It is with the madam. I think control is with madam, sir. So in case she can unmute, that is best.
Somebody should call her and tell her to unmute.
Yes.
Yeah, we'll call her. But thank you, sir. Thank you for sharing your very valuable experience. I was doing a cesarean, but I was listening with one ear to what you were saying.
About
And I think it's
fourth case about retaining the tubes, ovaries in the uterus. See, there is a faith in some people. People don't like to part away with their organs, whatever they say. Whether that one child, two child, three children, whatever is there. So that is important thing, and time again we are trying to find it out. Whatever has happened, we like to save the things as far as possible. Even we nowadays we save it for some time,
Unmute.
and then we can
Ji,
do
madam.
recognition at later part.
Ji.
But what he has done, we have done also in past. My senior doctor Pandya Sahib was there. She used to do macro surgery at the same time and try to save the tube. And as you said, one or two patients have conceived also later. So that faith has to be maintained. As you said, patient is always right. Whatever she wants to say, you have to keep that thing.
I want to one point to be emphasized here with all the people who are here, that when you are anastomosing the tube, make sure that the posterior stitch is taken first, because that becomes a very problematic if you start going around and then anteriorly, superiorly, and then going back. But the posterior stitch is with the first stitch which should be taken so that it's anchored together. And while you're doing it with all this mess around, the lumen can get obliterated as well. So the epidural cannula is the best thing. You thread it inside so that it remains, you get a feel of the cavity of the fallopian tube, and then you can suture it better. So that's something which is very interesting.
About the TO mass that you mentioned, used to get a lot of people with TO masses. It can be tuberculosis also, it can be gonococcal also, or anything else. And that time people used to remove, because we do not have very good antibiotics. People do not have, so they used to remove it whatever is possible, whatever the age. So we have seen so many cases later on also, then come 30, 40, 50 when marriageable age, then it is difficult to get. So drainage and putting it a drain or something, and whatever antibiotics. At our time, it was only garamycin, which was the highest. Now, lot many things have come up. So antibiotic cover is also important. So that is all. But nature always takes its own course also. So whatever you keep it, that might be stormy post-operative thing. But people used to get that they survive and they also get, as you said, get pregnancy also later. So TO-masis, even today, people like to remove whatever is possible. They remove tube also, so that you have to be careful about that. Laparoscopy also they do it, and sometimes they remove tube. Madam Shanti ji, boliye.
70, 75, all you had was ampicillin, penicillin, which
Yes,
is
penicillin, we used
not
to-
heard of nowadays. Being
reaction
given
rate
injection
was also very
penicillin.
high, but he
And
used to.
garamycin was like reaching the roof.
Yes,
If
yes.
you are in a government hospital, if you are able to get garamycin to give to the patient, it was like really. Anyway, the days are different, times are different now.
Madhuri ji, anything? Vinita, do you want to
Yeah.
say something?
Can I say something, sir?
Sure,
With your
Yes.
permission. Sir is an excellent surgeon, and which sir has narrated all his cases. They are really unique. And I must say that when I was with sir, we used to do the modified Vardham hysterectomy for the cancer service, and it has really helped. Sir's paper and everything is, whatever we do, sometimes our Indian innovation, people don't accept Indian also. So we have to see that we do that and we give the benefit to the patient. Sir, I had a very bad patient once. She came with infertility, primary infertility, 40 years old. And she was always crying because there was a severe pain in abdomen. And those days, sonography and all was just new things. And my madam decided to do hysterectomy. And what happened, sir, when we opened the abdomen, everything was clean. Not a single adhesion, sir. But we could not lift the uterus. So it was very surprising. There are no adhesion, flimsy adhesion, nothing was there. But it was only the uterus and ovaries and the fallopian tube. We could not lift it. And somehow the other we could finish the hysterectomy. And then the patient was asymptomatic. She was happy that I don't want children, but I'm really with my pain. So sometimes it happens that you don't see anything, everything is clear. But because of the frozen pelvis, especially uterus is such a we could not pull out. And in your case, sir, your senior pulled it out and told you to, do the repair. So that is a great thing to hear. And we everybody experience in our, life certain cases. And one more thing, sir has said that when you do tuboplasty, you must keep the catheter, feeding catheter. That is a very important tips everybody has got. Because, nowadays the culture is that if you don't conceive, your tubes are bad or your tubes are normal, you go for the IVF. But there are many patients, they cannot afford, sir. They come, how can we afford this IVF treatment? And then we have to justify them. And sir has given a very clear message. Okay, you put a feeding tube and take a posterior stitch first. So your tubal patency will be good and the patient can conceive. There is no problem in conceiving. So thank you, sir. Excellent thing. And Atul Munshi, sir, excellent your, inputs also. Thank you, team ICOG.
See, these days we get not many, but formerly we used to get post-tubectomy recanalization. That was very common. When the tube is pathological, it's difficult to get the results. But when tubectomy has occurred and that patient has somehow wanted to go for children or the other thing, then this kind of recanalization was quite useful. Now even it can be done with laparoscopy also, and it's done very nicely. But that is another, rather than going for IVF or other thing, it is always better to do microsurgery and get a tubes open.
So, sir, it was really a wonderful experience. And with your permission, I would like to tell some, funny experience which I had when I was postgraduate, sir. So I was second year student, and I said one of my intern ki, please jaw Foley's catheter laga do. He came running to me, madam, you know what has happened? Instead of urine, the blood is coming. So I said, "Ki, what happened to that patient?" I just ran and I saw that the Foley's catheter was not in the urethra, that was in the vagina. So it was a very good experience for me. Ki jab bhi aisa hoga, let us think ki whether it's all because of intern, he is not knowing anything. So that was my experience. We have lots of experience also, sir. So that was really very good hearing you, and I wish I would have been with CN sir and Atul Munshi sir to see all surgeries, but I'm really unfortunate I'm not there. So I know, sir, you are a very good surgeon. I have learned a lot. And this program has been initiated because of CN sir only. Because myself and Dr. Parul sir, we were sitting in a hall and sir was telling one experience ki kaise hua and how he saved that life, what he was telling today. And Parul sir said, we will start this program and all, senior legendary personality, they will tell us about their experiences. So it's really very good, sir. I'm so much thankful to CN sir for accepting today's invitation and becoming a part of this program. I'm thankful from core of my heart. And as expert, I'm really thankful to Atul Munshi sir. I have learned so much from you and you accepted my invitation to be the part of this program as expert, sir. So thank you very much, sir. You spared
When
your
you
time
say
for
Dr.
this.
Purandare is talking, I said without anything, I want
Yes,
to
I
say,
know.
yeah.
I know, sir. I know, sir. And also, I'm very much thankful to Padma Shri Dr. Professor Shanti Roy, madam, because she is my mentor. I did my post-graduation under her guide. She was my unit chief. So I was really very much thankful to her. She said, "Ki, Vinita, you are telling me, then I will be there." She was there, though there was some connectivity problem, but she heard everything. She gave me a call also. So thank you very much, madam, for being a part of this program. And also, I'm very much thankful to our president, Dr. Jaideep Tank. He's so dynamic and he organizes all the program. And I'm really very much thankful to our Madhuri Patel, madam, our secretary general. I don't know how much energy you have, madam. So you are always there in every program. How you make it, we have to learn a lot from you. So thank you very much, ma'am, for being a part of this program. And also, I'm very much thankful to our vice chair, our chairperson, Dr. Parul Kotawala, sir, as he is busy in some emergency, so he couldn't make to be the part of this program. And I'm thankful to Dr. Sheila Mane, vice chair. She was here. And also, I'm very thankful to Dr. Sarita Bhalero, a very dynamic and energetic secretary of ICOG. So I'm thankful to her, and I'm also thankful to Kiran Pandey, but she is not here, but she was with me to organize this program. So at the very end, I would like to thank everyone, all stalwarts, Pranam, and all participants who have participated in this program. There are so many, participants in this program. So thank you very much.
Congratulations to you for such a nice program.
Thank you, sir.
Yes,
Thank you
yes,
very much.
yes.
Thank you, sir. At last, I would like to say that I was,
Thank you.
I want,
Vinita.
yeah, thank you.
Vinita, thank you
Hi,
so much.
Shobha ji, thank you very much for becoming
And
a part
thank
of
you,
this program.
Purendran sir. It was a great learning experience today. Thank you so much, sir. It was a great learning. Actual pearls you have shared from your life's experience of the subject. We are so grateful, sir. A lot of learning has happened. Thank you so much. And Atul, sir, thanks for the interaction. That was lovely. Thank you, sir.
Yes.
Thank you. Thank
Thank
you,
you.
everybody.
Thank you.
Excellent
Thank you.
seminar,
Thank you.
excellent
Bye-bye.
webinar. Bye-bye.
We'll be
Bye-bye.
meeting soon for
Bye,
some
ma'am.
other.
Pranam, ma'am.
Bye.
Pranam.
Pranam. Namaskar.
Namaste, madam.
Thank you, everyone. Good night.
Okay. Okay.